myelodysplastic syndrome. So this myelodysplastic syndrome, so these are a heterogeneous group of hematological disorders. So what are these myelodysplastic syndromes? So these myelodysplastic syndromes are a heterogeneous group of hematological disorders. So these myelodysplastic syndromes, so they are characterized by cytopenias. Why cytopenias? Because of bone marrow failure, and there is a high risk of development of acute myeloid leukemia. So in this myelodysplastic syndrome, there is a high risk of development of AML and cytopenias. Cytopenias and AML. Anemia due to ineffective erythropoiesis, often with thrombocytopenia and neutropenia, occurs with dysmorphic abnormal appearing and usually cellular bone marrow, or with specific chromosome abnormalities or acquired mutations. So what happens here is there will be anemia. So why this anemia? It is due to ineffective erythropoiesis. So this anemia, it also will be accompanied by thrombocytopenia and neutropenia, and this also occurs with dysmorphic, that is abnormal appearing and usually cellular bone marrow. So how will the bone marrow be? So bone marrow will be cellular bone marrow and it will be dysmorphic, that is abnormal appearing and cellular bone marrow, and there also will be specific chromosome abnormalities or acquired mutations. So MDS means there will be cytopenias and there is a high risk of development of AML. So why anemia occurs? It is due to ineffective erythropoiesis. So this anemia will often be present with thrombocytopenia and neutropenia, and there also will be dysmorphic, that is abnormal appearing and cellular bone marrow. It is not hypocellular, but it is cellular bone marrow, and there will be specific chromosomal abnormalities or acquired mutations. So in patients with low risk MDS, what happens is marrow failure dominates the clinical course. In low risk MDS, what happens? Marrow failure, it will dominate the clinical course. In other patients, myeloblasts are present at diagnosis, chromosomes are abnormal, and the high risk is due to leukemia progression. Low risk means marrow failure, high risk means due to leukemia. So leukemia means there will be myeloblasts are present at diagnosis, chromosomes will be abnormal, and the high risk it is due to leukemia progression. So MDS may be fatal due most often to complications of pancytopenia or to progression to leukemia. But a large proportion of patients will die of concurrent disease. The comorbidity is typical in an elderly population. So why is the MDS fatal? It is due to either complication of pancytopenia or it could be to progression to leukemia. But a large proportion of the patients, they'll die of the concurrent disease. Useful nosology of these often confusing entities. So the first classification was developed by the French American British Cooperative Group in 1983. French American British Cooperative Group. So then 5 subtypes were defined. So what were those 5 subtypes? See, it will simply present as refractory anemia, or there could be refractory anemia with ringed sideroblast. Either it could be like a refractory anemia or refractory anemia with ringed sideroblast, refractory anemia with excess blast. So in high risk, we know that there will be excess blast. Refractory anemia with excess blast in transformation, and chronic myelomonocytic leukemia. So then classification 5 subtypes. So the World Health Organization classification 2002. Okay, so this was almost, when was this? It was in 1983. Then we have this WHO classification recognize that refractory anemia with excess blast and transformation and AML was arbitrary, and so this excess blast and transformation and AML, no, so they have grouped them together as acute leukemia, and they clarified that chronic myelomonocytic leukemia, it behaves as a myeloproliferative disease, and clarified that chronic myelomonocytic leukemia, so it behaves as a myeloproliferative disease. So now currently we have this 2016 WHO classification. So this is more refined, but it is also more complicated. Blast percentage remains critical in defining MDS categories. So to define the MDS categories, which is most critical? So blast percentage, how much percentage of blast are present. So this is the WHO classification in 2016. So this remains critical. So what remains critical? Blast percentage. Erythroid predominant leukemias, they are now largely regarded as MDS. Erythroid predominant leukemias, so now they are largely regarded as MDS. So defining cytogenetic abnormalities are reaffirmed under single somatic mutation. So if there is a single somatic mutation in SF3B1, so this is now a feature of sideroblastic anemia. A single somatic mutation in SF3B1 is now a feature of sideroblastic anemia. So identification of somatically mutated genes and their correlation with clinical outcomes will be increasingly important in defining classification, prognosis and targeting therapy. So what has to be done? Identification of somatically mutated genes and their correlation with clinical outcomes. Mutated genes and what is their correlation with clinical outcomes. So this is increasingly important in defining the classification, prognosis and targeting therapy. So the diagnosis of MDS can be a challenge even for the expert, because sometimes subtle clinical and pathological features must be distinguished, and precise diagnostic categorization requires a hematopathologist knowledgeable in the latest classification scheme. Okay, so the diagnosis of MDS can be a challenge. Unfortunately, agreement among pathologists on morphological features and classification is imperfect. Changes in the appearance of megakaryocytes are more reliable than loss of granules in neutrophil precursors or dyserythropoiesis. So the agreement among pathologists is imperfect. So what is more reliable? So the changes in the appearance of megakaryocytes are more reliable than changes in the appearance of megakaryocytes. So these are more reliable than loss of granules in the neutrophil precursors or dyserythropoiesis. Further, dysplastic changes, they can be observed in normal individuals. So this dysplastic changes, so these can be seen in normal individuals and they can occur either with vitamin deficiencies and as drug effects. So these dysplastic changes can be observed in normal individuals and they can occur with vitamin deficiencies and as drug effects. Genomic testing is increasingly routine and can be difficult to interpret, as in differences between somatic and germline mutations, pathogenic mutations versus those of unknown significance. Genomic testing, it is increasingly routine and it can be difficult to interpret. Why difficult to interpret? Because of differences between somatic and germline mutations, pathogenic mutations versus few mutations which are of unknown significance. And what happens is this clonal hematopoiesis increases in frequency with age and involves genetic changes. So these changes may be clinically silent or they convey an increased risk of hematological malignancy, and also the clone size, so it changes over time. So it is important that the internist and primary care physician be sufficiently familiar with MDS to expedite referral to a hematologist. And then this is the WHO classification of myelodysplastic syndrome or neoplasia. So here we have myelodysplastic syndrome with single lineage dysplasia, only single lineage, and then we have MDS with multi-lineage dysplasia. So because this is only a single lineage dysplasia and multi-lineage dysplasia, see here you can see that ringed sideroblast should be less than 15%. See, if MDS with ringed sideroblast means sideroblast should be greater than or equal to 15%. So what is the number that has to be remembered? So it is 15%. Ringed sideroblast, to classify MDS with ringed sideroblast, so it should be greater than 15%. But if there is SF3B1 mutation, if it is present, then ringed sideroblast should be greater than or equal to 5%. And in all these cases, so here only ringed sideroblasts are there. So myeloblasts. So if we take this myeloblast, so this myeloblast in the bone marrow should be less than 5% in the bone marrow and less than 1% in the peripheral blood. So if excess blast 1 and 2. So here excess blast 1 means 5 to 9%. Excess blast 2 is 10 to 19%. So peripheral blood also. So this excess blast will be 5 to 19% or rods. So MDS with single lineage dysplasia, that is either red blood cells, or multi-lineage dysplasia, or MDS with ringed sideroblast. So if ringed sideroblast means greater than 15%, if there is a gene mutation, ringed sideroblast should be greater than or equal to 5%. But here all the blast will be less than 5%. If blast are 5 to 9%, then we have this MDS with excess blast. So then we also have this MDS unclassifiable, that is with 1% blood blast, with the single lineage dysplasia and pancytopenia, and based on defining cytogenetic abnormality. Here you can see the karyotype, any unless fulfills all criteria for MDS with isolated deletion 5q. So chromosomal abnormality can be present. So any karyotype, or it fulfills all criteria for MDS along with that isolated deletion 5q. So here also we have this MDS with isolated deletion 5q. Okay, so here deletion 5q alone or with one additional abnormality except -7 or deletion 7q. So here it should not be -7 or deletion 7q. So here any karyotype can be present. Then we have the epidemiology. So in epidemiology, so this MDS is a disease of the elderly, mean age of the onset, older age. So it is older than 70 years, and there is a slight male predominance. And it is relatively common form of bone marrow failure, and reported instances 35 to greater than 100 million persons. So rates of MDS, they have increased over time due to better recognition of the syndrome by physicians and aging population. MDS, it is rare in children in whom it often has a constitutional genetic basis. So in children, if MDS occurs, so it has a constitutional genetic basis. So this can be identified on genomic screens of myeloid cancer predisposition panels. MDS is rare in children. It has got a constitutional genetic basis, and this can be identified on genomic screens of myeloid cancer predisposition panels. And then we have secondary or therapy related MDS. Secondary or therapy related MDS. So this is usually related to previous iatrogenic exposure to alkylating agents and other chemotherapy as well as radiation. So this is not age related. That is, if patient was previously exposed to alkylating agents and other chemotherapy agents, so then we have the secondary or therapy related MDS. So what is the etiology and pathophysiology? So MDS is associated with environmental exposures. So in environment, radiation and benzene. Okay. MDS environment, yes, environment also plays a role. Radiation and benzene. Other risk factors reported inconsistently. So radiation and benzene has to be remembered. And secondary, that is therapy related MDS. See, patient has taken cancer treatment and later patient has developed MDS. Environmental exposure is there and therapy related MDS. So if patient has taken radiation and the radiomimetic alkylating agents such as busulfan, nitrosourea or procarbazine, okay, so if patient has taken radiation and radiomimetic alkylating agents such as busulfan, nitrosourea or procarbazine, so with a latent period of 5 to 7 years, patient can develop MDS. Or if patient has taken treatment with DNA topoisomerase inhibitors, so there will be a 2-year latency. DNA topoisomerase inhibitor, what is the latency? With DNA topoisomerase inhibitor, it is a 2-year latency. Secondary therapy related MDS, it occurs as a late toxicity of cancer treatment, radiation and radiomimetic alkylating agent. And then we have acquired aplastic anemia, Fanconi anemia and other constitutional marrow failure disorders. So these can evolve into MDS. You see, if patient has got this acquired aplastic anemia, or if patient has got Fanconi's anemia or other constitutional marrow failure disorders, so these can also evolve into MDS. And occasionally MDS in adults, it is recognized as due to germline GATA2 RUNX1 or telomere gene mutations. So even MDS in adults, so this is also recognized as due to a germline GATA2 RUNX1 or telomere gene mutations. The typical MDS patient does not have a suggestive environmental exposure history or a preceding hematological disease. The typical MDS patient, so does not have a suggestive environmental exposure history or a preceding hematological disease. So MDS is a disease of aging. So this is a disease of aging. Consistent with aging, what will happen? Accumulation of mutations within a hematopoietic stem cell in an aging marrow environment. Aging marrow environment, what will happen? There will be accumulation of mutations within a hematopoietic stem cell in an aging marrow environment. So this MDS, it is a clonal hematopoietic stem cell disorder. Clonal hematopoietic stem cell disorder. So this is characterized by disordered cell proliferation, impaired differentiation and aberrant hematopoiesis. So stem cell disorder, clonal hematopoietic stem cell disorder. So this is characterized by disordered cell proliferation. Cell proliferation is disordered, impaired differentiation and aberrant hematopoiesis. So this will result in cytopenias and also there is a risk of leukemia. So it is characterized by cytopenias and risk of leukemia. Both chromosomal and genetic instability have been implicated and both are aging related. So both chromosomal and genetic instability have been implicated. Chromosomal and genetic instability. Cytogenetic abnormalities are found in approximately 1/2 of patients and some of the same specific lesions are also seen in leukemia. So cytogenetic abnormalities, they are found in approximately 1/2 of patients and some of the same specific lesions whatever found in MDS are also seen in leukemia. Aneuploidy, that is chromosomal loss or gain is more frequent than translocations. Aneuploidy, that is chromosomal loss or gain is more frequent compared to translocations, which is more frequent. Aneuploidy, okay, aneuploidy. So accelerated telomere attrition may destabilize the genome in marrow failure and predispose to acquisition of chromosomal lesions. So what happens? Accelerated telomere attrition. So this accelerated telomere attrition, no, it will destabilize the genome in marrow failure and predispose to, so this will predispose to acquisition of chromosomal lesions. So cytogenetic abnormalities are not random. Loss of all or part of 5, 7 and 20, trisomy of 8. So they are not random and may be related to etiology. That is, following topoisomerase 2 inhibitors. So what cytogenetic abnormality? It can be seen in 11q23. So cytogenetic abnormalities are not random. That is, if there is any loss or part of 5, 7 and 20. So these are not random. So the type and number of cytogenetic abnormalities strongly correlate with the probability of leukemic transformation and survival. So the type and number of cytogenetic abnormalities. So there is a strong correlation with probability of the leukemic transformation. Okay, so it depends on the what type and what is the number of cytogenetic abnormalities. So these strongly correlate with the probability of leukemic transformation and survival. Genomics has eliminated the role of specific mutations and distinct molecular pathways in the pathophysiology of MDS. Somatic mutations in about 100 genes which are recurrently present in myeloid neoplasms and are acquired in about 100 genes arise in the abnormal marrow cells and are absent in the germline. So many of the same genes are mutated in AML and in MDS, whereas others are distinctive in subtypes of MDS. Somatic mutations in about 100 genes which are recurrently present in myeloid neoplasms. So even in myeloid neoplasms, so these somatic mutations are present and few mutations are acquired. So these mutations arise in the abnormal marrow cells. So same genes are mutated in AML and in MDS. So if we take an example of SF3B1 in which mutations strongly associate with sideroblastic anemia. Supposing if we take example of SF3B1, okay, so this is important, SF3B1. So these mutations strongly associate with sideroblastic anemia. Some mutations correlate with prognosis. Spliceosome defects like SF3B1 correlate with favorable outcome. So a few mutations, they correlate with prognosis. Few mutations, they correlate with prognosis. Spliceosome defects like SF3B1, they correlate with favorable outcome. And if we take mutations in EZH2, TP53, RUNX1 and ASXL1 with poor outcome, SF3B1 favorable outcome. But if we take mutations in EZH2, TP53, RUNX1 and AXL1 with poor outcome. Mutations in EZH2, TP53, RUNX1 and ASXL1 with poor outcome. So correlation and exclusion in the pattern of mutations indicate a functional genomic architecture. Driver genes mutated early or consistent with normal blood counts and marrow morphology. Okay, driver genes mutated early. Okay, so genes which were mutated early, so they are consistent with normal blood counts and marrow morphology. But these expanded clones of cells containing them, so if the cells are expanded clones of these cells containing them, so they are susceptible to malignant transformation because there will be acquisition of the additional mutations. And deep sequencing results in patients whose MDS evolved to AML have shown clonal succession with founder clones acquiring additional mutations to produce clonal dominance. So deep sequencing, so this results in so deep sequencing results in patients. See, MDS has evolved to AML in few patients. So if the deep sequencing, if it is done in those patients, they have shown the clonal succession. So with founder clones acquiring additional mutations, so there is a clonal dominance. And mutations and cytogenetic abnormalities are not independent. Mutations, cytogenetic abnormalities, they are not dependent, not independent, that is they are dependent. So TP53 mutations associate with complex cytogenetic abnormalities and TET mutations with normal cytogenetics. So if there are TP53 mutations, they are associated with complex cytogenetic abnormalities, and if there are TET mutations, normal cytogenetics. So the prevalence of abnormal cells by morphology underestimates bone marrow involvement by MDS clones, as cells normal in appearance or derived from the abnormal clones. So the prevalence of abnormal cells by morphology underestimates bone marrow involvement by MDS clones, as cells normal in appearance, so they are derived from the abnormal clones. So those cells are normal in appearance, they are derived from the abnormal clones. So presenting and evolving hematological manifestation result from the accumulation of multiple genetic lesions. See, this presentation and evolving hematological manifestation. So why they result? Because of the accumulation of multiple genetic lesions, that is loss of tumor suppressor genes, loss of tumor suppressor genes are lost, activating oncogene and epigenetic pathways, and also because of epigenetic pathways. So these pathways affect the mRNA processing and methylation status or other harmful alterations. Epigenetic pathways that affect the mRNA processing and methylation status or other harmful alterations. Pathophysiology has been linked to mutations and chromosomal abnormalities in some specific MDS syndromes. So the 5q minus deletion leads to, so if there is a 5q minus deletion, so this will lead to heterozygous loss of a ribosomal proteins gene. 5q deletion leads to what happens because of 5q deletion. So this will lead to heterozygous loss of a ribosomal protein gene. So this mimics constitutional red cell aplasia. And immune pathophysiology may be important in lower risk MDS. If we take this lower risk MDS, immune pathophysiology may be important because cytopenias can respond to immunosuppressive therapy as administered for aplastic anemia. In low risk MDS, immune pathophysiology, so patient can respond with immunosuppressive therapy like in aplastic anemia. In general for MDS, the role of the immune system, in general for MDS, the role of immune system and its cell and cytokines, role of immune system, cell, cytokines, the role of the hematopoietic stem cell niche, the microenvironment and cell-to-cell interactions, the fate of normal cells in the Darwinian competitive environment of the dysplastic marrow, and how mutant cells produce marrow failure in MDS are still not completely understood. So then going to the clinical features of MDS. So in MDS, anemia, okay, so first refractory anemia, so anemia dominates the early course. Most symptomatic patients complain of the, because of anemia there will be fatigue, weakness and dyspnea and pallor, but at least one half of the patients are asymptomatic and their MDS is discovered only incidentally on routine blood counts. So anemia dominates the early course. Refractory anemia, so previous chemotherapy or radiation exposure, so this is also an important historic fact. If there is fever and weight loss, they are more often features of a myeloproliferative rather than myelodysplastic process. Fever and weight loss are more often features of a myeloproliferative rather than a myelodysplastic process. MDS in childhood is rare and when diagnosed, so this implicates an underlying genetic disease. So MDS in childhood is rare, but if found MDS in childhood, it implies some underlying genetic disease is there. That is, children with Down syndrome are susceptible to MDS as well as leukemia. So MDS means leukemia can be seen in Down syndrome. So children with Down syndrome are susceptible to MDS as well as leukemia. A family history may indicate a hereditary form of sideroblastic anemia, Fanconi's anemia or a telomeropathy. So in children, if there is a family history, so this indicates a hereditary form of sideroblastic anemia, Fanconi's anemia or a telomeropathy. Inherited GATA2 mutations as in the Monomax syndrome, See, if this inherited GATA2 mutations, no, so this will lead to increased susceptibility to viral, mycobacterial and fungal infections, as well as deficient numbers of monocytes, natural killer cells and B lymphocytes predisposed to MDS. So in monomax syndrome, so there will be increased susceptibility to viral, mycobacterial and fungal infections, as well as there will be a deficient number of monocytes, natural killer cells and B lymphocytes. They predispose to MDS. And germline RUNX1 mutations also confer a high risk of MDS and leukemia, often preceded by years of modest thrombocytopenia, supposing if there is a germline RUNX1 mutation. So this germline RUNX1 mutation, so they also confer a high risk of MDS and leukemia. So this will often be preceded by years of modest thrombocytopenia. A family history is important in all MDS patients, as constitutional mutations may not result in manifest disease until adulthood. So family history is important because constitutional mutations may not result in manifestation of the disease until adulthood. So the physical examination, if we do a physical examination, there will be signs of anemia, and approximately 20% of the patients we can also see splenomegaly. So anemia will be there, and in 20% of the patients splenomegaly also will be there. And patient also can have this unusual skin lesions. So what are these unusual skin lesions? Including Sweets syndrome, febrile neutrophilic dermatosis. So this occurs with MDS. What are the skin lesions that occur with MDS? Sweets syndrome, that is febrile neutrophilic dermatosis occur with MDS. Accompanying autoimmune syndromes are not infrequent. So even autoimmune syndromes are also frequent. In the younger patient, stereotypical anomalies point to a constitutional syndrome. So in a younger patient, if there are few anomalies, so this will lead to a constitutional syndrome. So this includes short stature, abnormal thumbs in Fanconi's anemia. So if early graying is there, so it suggests telomeropathies. Cutaneous warts will be there in GATA2 deficiency. So in the younger patient, if there are some stereotypical anomalies like short stature, abnormal thumbs in Fanconi's anemia, so early graying of the hair will be seen in telomeropathies, and cutaneous warts will be seen in GATA2 deficiency. So then coming to the laboratory studies, so that will be discussed in the next session.